Well, good afternoon, everyone. My name is Bill Gradisher, Professor of Medicine and Chief of Hematology Oncology at Northwestern University. I'm a medical oncologist with a focus in breast cancer, and I'm pleased to be moderating this panel, which is entitled Social Determinants of Health and Breast Cancer. And I'm joined today by three exceptional panelists who are going to give their own perspectives on this topic. This topic seems to be residing in so-called Breast Cancer Awareness Month, but clearly it's something that has a time and place every day that we work. And I think that the discussion today is going to be relevant not only to breast cancer, but of course to all other aspects of health. And you'll hear some of that from our speakers today. So I don't want to take up any time with an introduction of my own. I want to just give the opportunity to our panelists to really give a sense of what their work is about and how it intersects with the topic that we'll be talking about today. And our first panelist is Dr. Samilia Obeng-Gyasi, who's a faculty member at Ohio State, or I should say the Ohio State. The is very important, apparently. She's a graduate from medical school, the University of Michigan, completed surgery at Cleveland Clinic and did a surgical fellowship in breast cancer oncology at Duke University, and then subsequently went on to get an MPH at Harvard. And she really focuses on healthcare disparities, and we'll be discussing some of that as it applies to the topic today. So I'm going to turn it over to Samilia to get us started.
So thank you very much for the opportunity to talk to you today. My name is Samilia Obeng-Gyasi, and as it was stated, I am a breast surgical oncologist here at The Ohio State University. And the title of my talk is Social Determinants of Health and Breast Cancer. In addition to my clinical responsibilities seeing patients who have both benign and malignant breast disease, I'm also a health services researcher with a focus in healthcare disparities and also health equity. I don't have any financial disclosures. So before we delve into social determinants of health, we're going to talk about a fictional patient who will help contextualize that. So I'd like for you to meet Lisa. Lisa is a 36-year-old single mother of one. She lives in a neighborhood that's resource poor. What that means is that she doesn't have a lot of opportunities for employment. There's not a lot of healthy food in the grocery stores in her neighborhood. Actually, her neighborhood has been called a health food desert or a healthy food desert. Also, the built environment, which is how the neighborhood is structured, is not really amenable to exercise. So if she wanted to go outside and exercise, she wouldn't be able to. She has a job in the neighboring community, but it's a very stressful job. She doesn't get along with her boss, and also she doesn't have very much control over her work environment. She makes enough money to be above the federal poverty level, and she also has some money in her savings. But if she is to face a very expensive life event, it will be financially catastrophic for her. She has a very limited social network. Her parents live in a different state. Her siblings live in different cities. She doesn't have very many friends at work, and actually she has even fewer friends at home. And if you were to ask her, she would tell you that she feels pretty socially isolated. She's about to discover that she's underinsured, meaning that because of this cancer diagnosis, she's going to spend about 20% of her income on deductibles, copays, and coinsurance. The scenario I just describes social determinants of health. And social determinants of health describe our living and our working conditions and can powerfully influence our overall health outcomes. In this particular slide, we look at what percentage of our overall health is contributed by genetic predisposition, which is about 30%, and then by social determinants of health, which is the other 70%. So what this is conveying to us is that things like healthcare, social circumstance, behavioral patterns, and environmental exposure contribute more to our overall health, than genetic predisposition. Once again, reiterating that social determinants of health have significant implications for our health. Now, social determinants of health can result in differences in health and healthcare. And those differences are called a health disparity and a healthcare disparity. So a health disparity describes a higher burden of illness, injury, disability, or mortality experienced by one population group relative to another. An example of a health disparity is the higher rates of cystic fibrosis among individuals who identify as white compared to individuals who identify as Black. A healthcare disparity describes differences between groups in health insurance coverage, access to, and use of care, and quality of care. So an example of a healthcare disparity is the higher rates of uninsurance among individuals who identify as Hispanic. Now, the intersection of social determinants of health, health disparities, and healthcare disparities is health equity. And health equity describes the ability of everybody in a society to reach their full health potential. Specifically, no one is disadvantaged from achieving this potential because of social position or socially determined circumstance, which once again broadly describes social determinants of health. Now, for breast cancer patients, social determinants of health have been implicated in outcomes from stage of diagnosis all the way through mortality. For example, women who live in rural areas and women who have a low socioeconomic status are more likely to present with advanced stages of cancer compared to women who live in neighborhoods with a high socioeconomic status or those who live in a metropolitan area. Additionally, women who report social isolation, Black women who live in racially segregated neighborhoods, and individuals who live in neighborhoods with a low socioeconomic status are more likely to present with aggressive tumor characteristics. Lastly, individuals who are privately insured or uninsured, or individuals who live in neighborhoods with a low socioeconomic status are more likely to die from their breast cancer than individuals who are privately insured or those who have live in neighborhoods with a high socioeconomic status. And so what this slide reiterates to us is that social determinants of health have significant implications for cancer stage of diagnosis, for tumor characteristics, and also can affect or are associated with worse mortality if they're adverse social determinants of health. So then this brings us to our next question, which is, what is the mechanistic pathway from social determinants of health to cancer initiation, progression, and metastases? Metastases is the spread of cancer. Now, to understand this, we have to understand the stress response, because some people believe that the way that the social environment becomes embedded in our physiology and also at the molecular level is through the stress response. So let's go through a hypothetical scenario for the stress response. Let's imagine we're being chased by this monster. In order to get away from this monster, our body is going to go through a series of physiologic changes. First, we're going to have auditory exclusion to improve our hearing. Our heart rate is going to go up, and so is our blood pressure. Our pupils are going to dilate to improve our vision. Our body is going to liberate energy from sugars and also from fats. Our breathing is going to increase the amount of oxygen we have to also help perfuse our brain better. And then the body is going to shunt blood to the muscles to help us run away. These physiologic changes are temporary and are in response to this external stressor. When this stressor goes away, our body is going to go back to its baseline. For some individuals, they have a chronic monster in their life, which is in the form of adverse social determinants of health. And these include socio-environmental factors that have negative effects on individuals. Examples of this include social isolation, work-related stress, and financial instability. What happens is that once the body perceives this negative or adverse social determinants of health, it works through the hypothalamic, pituitary, and adrenal axis, which is a stress response, to result in physiologic changes. When these physiologic changes are chronic and persistent, this can then result in illnesses such as hypertension, diabetes, obesity, insomnia, and in some cases also cancer. Studies have also shown that these adverse social determinants of health do not just affect our physiology, but they also have implications at the molecular level, resulting in changes or DNA modification and also changes in DNA translation, which is how the DNA is read, which is a part of a study or a part of a line of thought called epigenetics. So the key from this slide is that individuals who face adverse or persistent external stressors can have chronic changes in their physiologic system and also can have molecular changes, which can have significant implications for the initiation, progression, and also metastases of cancer. So how do we conceptualize this, or how do we measure this? And one way to think about this is the concept of allostatic load. So allostatic load is rooted in the concept of allostasis. And allostasis describes the body's ability to maintain stability or homeostasis through change. Allostatic load or allostatic overload describes physiologic dysregulation secondary to exposure to chronic stress. So essentially, negative or adverse socio-environmental factors can result in persistent or chronic physiologic changes, which can then result in chronic illnesses such as diabetes and also hypertension, as I alluded to earlier. Now, the way we measure allostatic load is that it's a composite score of multiple physiologic systems. It includes markers from the neuroendocrine system, so primary mediators such as cortisol. It also includes secondary outcomes of primary mediators, so things like systolic blood pressure, body mass index, albumin, C-reactive protein, and it also includes tertiary outcomes like hypertension. Essentially, allostatic load allows us to operationalize the effects of socio-environmental stressors on our physiology and to help us understand how that can have implications for cancer initiation, progression, and also metastases. Now, this underlying hypothesis has some signals. So studies have been done looking at the relationship between elevated allostatic load and social determinants of health. I want to point out that a high allostatic load is associated with a higher physiologic dysregulation, whereas a low allostatic load obviously is associated with a lower physiologic dysregulation. And what studies have shown are that individuals who face adverse social determinants of health, so people who have traumatic childhoods, individuals living in areas of who themselves have low socioeconomic status, individuals with low educational achievement, and also minoritized and marginalized populations, such as Black women, have a higher allostatic load than individuals who have not faced some of the adversity that I've just described. Studies have also shown that older adults who have high allostatic load are more likely to experience both physical and cognitive decline. For breast cancer patients in particular, high allostatic load has been associated with poor tumor characteristics, such as a larger tumor size and also poorly differentiated tumors. And studies have shown that individuals who have a high allostatic load also have a worse mortality. Now, in my work with the ECOG-ACRIN group, we were interested in understanding if allostatic load at study entry was associated with chemotherapy completion among women who were enrolled in the ECOG-ACRIN clinical trial E5103. E5103 was an adjuvant breast cancer trial looking at the addition of bevacizumab to adjuvant chemotherapy. And it looked at women who were node positive or high-risk node negative, who had high-risk node negative cancers. And in the study, we looked at both genetic ancestry and genetic ancestry and allostatic load. The majority of the sample was of European ancestry, and then the remaining 20% were of African ancestry or other ancestry. Other ancestry is comprised of individuals who were not European or African ancestry, and their numbers were too small to look at them independently, so they were grouped as one. What we found, which is consistent with other studies, is that individuals with African ancestry had a higher allostatic load than those of European and other ancestry. But one of our interesting findings was that individuals who had a high allostatic load at baseline were less likely to complete chemotherapy, suggesting that high allostatic load correlates probably with chronic stressors or adverse social determinants of health, which even within the clinical trial setting where access to care is equal, still may have an influence on treatment tolerability and also treatment completion. Among cancer patients in general, studies have shown that every 1 unit increase in allostatic load is associated with a 9% increase in cancer-specific mortality, once again suggesting that socio-environmental factors can become embedded in our physiology and also at the molecular level and can have implications for tumor characteristics, for how we respond to treatment, and also in the long term for our survival from cancer. So the main takeaways from this brief talk are that social determinants of health are very powerful drivers of health and clinical outcomes. It is hypothesized that these social determinants of health work through the stress pathway. And currently, we need to do additional research to really elucidate the pathway of how these social determinants of health essentially become embedded. Specifically, is allostatic load a moderator or a mediator of this relationship between social determinants of health and then breast cancer etiology through survivorship? Specifically, how does this relate across the cancer continuum? Once again, thanks for your time. Here's my email address if you have any questions, and then here's my Twitter handle if you would like to follow me.
Thank you very much, Samilia. So I want to emphasize to everyone who's listening that we have a question and answer period at the end of the talks, and it'd be great if you could submit your questions there, and we'll try to get to as many of them as possible. So transitioning now to our next speaker is Mita Goel, and she's an associate professor of medicine here at Northwestern University in the Division of General Internal Medicine and Geriatrics. Mita completed her internal medicine training in Boston at the Beth Israel Deaconess Hospital. She currently serves as Director of Population Health and Equity Education at the medical school here and is Director of the dual MD-MPH program, so helping develop the next generation of investigators. She's also principal investigator for a health research services administration project that is really focusing on preparing the primary care workforce to identify and address some of the issues that we're talking about today and that Samilia highlighted. So I'll turn it to her, and we'll again have time at the end for questions.
Great, thank you for that wonderful introduction, and thank you to Dr. Obeng-Gyasi for that excellent setup for what we're going to be talking about. So if anything, I believe that prior discussion really set us up to understand the impact of social determinants of health on overall outcomes. So you may be wondering now, what do we do about that? So let's think about this. And again, grounding a lot of our discussion around the guiding principle that every person deserves an equal chance at life after breast cancer, and ideally minimizing their chance of ever having experienced a diagnosis and treatment for breast cancer as well. But the current reality is quite different from this idealized version of giving everyone an equal chance at life. As we were hearing, for breast cancer, when we're looking at racial ethnic disparities in outcomes from breast cancer, the relative risk of death is substantially higher if you are a Black American or if you are a Hispanic American. And it's important to recall that these disparities in outcomes from breast cancer and in cancer in general are largely driven by disparities in social determinants of health, which can have a variety of different effects. As we were hearing, it could increase your incidence or your chances of getting breast cancer. It can influence the type of breast cancer that you're getting, either by it being more aggressive or being detected at a later date. It also influences whether or not you're going to achieve or complete the recommended therapies, as Dr. Obeng-Gyasi was pointing out through her research. And ultimately, it can lead to an increased risk of mortality. So it's very important as we try to think about how we're going to impact outcomes to think about what the primary drivers of these disparities in outcomes from breast cancer can be. But it can be overwhelming. As we talked about, we're talking about everything from neighborhood characteristics to occupation to whether or not you have health insurance. So how do we actually action this and make it more manageable? To do that, I really rely on the National Academies of Medicine framework around how we integrate social care into the clinical settings. So as you can see here, there are 5 different categories, or the 5 A's. And at the center of this is awareness. If at first we do not understand the social determinants of health or those social risk factors that influence an individual, we can't possibly impact them. So we need to start by understanding and measuring. But we can't just stop there and ask questions. We need to think about, what do we do with that information? And at the top of this, you can see adjustment and assistance. So those are activities that are focused on individuals. So once someone walks through the doors of a health institution, we can think about, well, if someone needs radiation therapy and they're traveling long distances, perhaps we can actually help them by setting up care closer to home. Or if they need follow-up or have questions, rather than having them travel in for a visit, perhaps setting up a telemedicine visit. So we adjust our clinical care to fit that individual. The top right box here is assistance. So if we identify that someone is struggling with food insecurity, there are things that we can do within a clinical setting. Have they applied for SNAP benefits or Supplemental Nutritional Assistance Program benefits? Are they eligible to receive deliveries from food pantries in their area? Often, our health systems have access to community resources that can be helpful for patients. so we can truly assist them with social needs. The bottom of this is really those activities that are focused on communities, sort of the holy grail of how do we work the furthest upstream to affect the policies and access to resources that affect individuals, so we can align our communities and our health systems to provide care. For example, if we note that there is not just a food desert, but perhaps an access to healthcare desert within our communities, we can site clinical care to provide care where patients live. So we can align our health systems and community needs. And we can also advocate, that bottom right here. So we can advocate for things to change. These are things like the Affordable Care Act. So how do individuals pool their risk to be able to have access to health insurance? And there are a variety of other upstream policies that can be advocated for that can enhance an individual's access to opportunity. So I'm going to talk a little bit about some of the work that I've done with one of our local health centers. But to really operationalize this framework, we first started by focusing on awareness. So within the clinical setting, we can't treat what we don't know about. So let's start with asking questions around what needs might be. And secondly, we really focused on assistance. So what can we do as a health system to link patients to resources that we're already aware of? And so we translated this into a framework of action, not unlike a typical clinical encounter. So when someone comes in the door at a health center, how do we not just diagnose their breast cancer, but how do we diagnose what their social needs might be? And how do we treat that the same? We have to then think about how do we link someone to resources. So I have a list of some of the common social needs that might occur within a patient population and things that we can perhaps identify and provide them with. So we can treat housing instability by knowing what resources are available. So do we have access to low-income housing? Are there other temporary forms of shelter that we can provide for someone that doesn't have a place to stay, let's say tonight? We can provide reliable food access in communities. So in essence, we can think about how do we not just diagnose, but how do we treat those social needs? And then downstream, how do we examine what the outcomes are on health? Are they able to access preventive healthcare like mammography screening? Are they more likely to complete recommended chemotherapy? So that's sort of the framework that we use to translate some of these bigger concepts into action. And I've been working on this actively with a partnership with Erie Family Health Center, which is a federally qualified community health center in the Chicagoland area, with generous funding from Wintrust, which is a bank in the local Chicago area, as well as with the tremendous support of Northwestern Medicine and with Lurie Cancer Center. So to tell you a little bit about the site where we did our work, Erie Family Health Center has 13 locations in the Chicagoland area that provide primary care in a variety of different settings. They serve over 80,000 patients every year and have over 350,000 visits to their clinical sites every year. Their patient population is largely Latino, and they have a high proportion that prefer Spanish as their primary language. So it's really important to think about how do we deliver culturally relevant, culturally tailored services in the language of choice. In addition, about over 90% come from low-income households, and many are uninsured or underinsured, with 25% uninsured and over 60% on Medicaid. So again, when we think about populations that might experience adverse social determinants of health, Erie Family Health Center has served a very large population that is at risk. So what we did, over the past 2 years, we set up some goals. So again, this predates some of the national dialogue around the importance of social determinants of health, which really tells us how important it is to lay a solid foundation prior to things like COVID hitting. So in year 1 and 2, what we did was we assembled stakeholders. So to do this work, we cannot just have clinicians and researchers at the table. We brought together patients, other staff members at the clinics that care for patients, either in a check-in, check-out capacity, manage medical records so that we can either capture information and share it accurately. So we brought together all of these stakeholders. We looked at what's available out there. It turns out when we talk about social determinants of health, while it can be quite broad, it can also be narrowed in a somewhat a reasonable manner. So I have an example here of a screener that was used at Boston Medical Center called the Thrive tool. And as you can see, it really nicely lays out just a couple of areas that we could ask questions to our patients about where they might be struggling. Things like housing, food, can you afford medications? Do you have difficulties with transportation? Can you afford your electrical bill? So important social determinants of health that we can narrow down. And then furthermore, ask, would you like to be connected to resources? Perhaps someone just has an occasional blip in their ability to access and feels like tomorrow will be okay, but others may really be struggling. So looking at all of the ways that we can ask these questions and assembling all of these potential screening tools, we then recognize the importance of saying, maybe this is or isn't applicable to the patient population at Erie Family Health Center. Perhaps they struggle with issues around immigration more than other health centers may. So we always need to think about how do we adapt some of these questions to the local context. We were going to gather pilot data and then identify what the needs were. We had these grand plans to really draw specific links between, are there certain social determinants of health that affect screening mammography more than others? But as with most plans, they went awry, particularly with the onset of COVID. Fortunately, we had a very strong foundation already laid with Erie Family Health Center and the patient populations there, such that we were able to pivot our in-person operations to virtual outreach. So this is another shout out to the importance of having strong community relationships. We had individuals who were staff members at Erie Family Health Center that were suddenly not working in-person capacity and volunteered to pivot their roles to virtual outreach. We had research assistants who were bilingual, bicultural at Northwestern, who volunteered time above and beyond their regular days to reach out to patients to ask them about what needs they had. And so rather than talking about the framework, let me talk to you about what we learned. So we originally set out to only talk with initially 100 women, ultimately 200 women, to ask them about what their barriers to care were. Because of the groundwork that we had laid and our ability to transition to virtual platforms and to integrate our processes into all 13 healthcare settings, to date, we have asked over 4,000 women what they might need. And these are all women that are eligible for mammography screening. Over 1,000 women reported that they had needs. When we look at that, that was a phenomenal number of women that had not had their needs identified before. And we were able to then link over 600 of those individuals to resources that they required within the community. And you might wonder, why is there that drop-off? That drop-off is all women had been offered resources, but don't always want them at that moment in time. And so they're available to call back at any point in time and be linked to resources should they desire. The most common needs that we found among women that were being screened were that 2/3 of women reported that their household income had dropped as a result since the onset of COVID. So again, employment opportunities shifted dramatically during COVID, affecting one's ability to pay for some of those out-of-pocket costs that Dr. Obeng-Gyasi had mentioned. 60% reported having difficulties affording their rent, and 50% had difficulties getting food. So you can imagine these are extremely basic needs that individuals were reporting, and these had not been identified prior to instituting this screening. It's also important to note that when we look at individuals reporting needs compared to those that didn't, women with needs were substantially less likely to have gotten screening mammograms. And this was early on in COVID. And while we know that screening rates are dropping likely over time as a result of access or desire to access healthcare, this was happening even prior to COVID and likely has been exacerbated in the era of COVID. What we were surprised to find is that by putting this in place for not just breast cancer, but for all patients at all Erie locations, we had a multiplier effect. So while we're focusing on breast cancer today, it's important to recall that social determinants of health affect far more So if we think about these upstream factors, they're important to identify for a variety of reasons, including access to other preventive health services and treatment of common chronic diseases like hypertension or diabetes. So as a result of this work at Erie Family Health Center, we asked over 70,000 times what individuals need. Over 18,000 referrals were made to resources. And most individuals that reported a need didn't just have one. On average, individuals with needs were more likely to report not just housing, but housing and food insecurity. So important to remember that often these come clumped together. Interestingly enough, this also changed the culture at Erie. So often clinicians may be wary about opening up this Pandora's box around, do you have a place to live? But once this program was in place, clinicians started identifying individuals' needs that had not been even identified through screening. And so multiple patients were referred over to the program directly by clinicians, even if they had not been screened or had previously screened negative. And we did a lot of work around delivering. So even just one of the health needs or the social needs that were identified, we were able to address very effectively through community partnership. And this is really critical. So you don't want to identify a need and not be able to do anything about it. So we had resources in place ahead of time. So for food delivery, thousands of food boxes have been delivered to individuals struggling with food insecurity to over 1,000 different families. And the influence didn't just stop there. It turns out that because we had this groundwork in place prior to COVID, and we're able to do a lot during the era of COVID, this program is now serving as a gold standard for what is happening at multiple Chicago-based healthcare institutions. In fact, Erie has been generous enough to share this data from this project with Northwestern, such that we are starting to use their data to help us start at a higher level of what we can do and how we can do to identify social determinants of health within the clinical setting. And just to remember, we talked a lot about numbers, but behind each of these numbers are individuals. And so I share with you a quote from one of the patients that had been identified and impacted by this project. This patient said that I can't thank you enough for the help you gave me last November when I got sick with COVID. You cared about me. You cared about me. And you sent delicious food, fruits, vegetables, and chicken to my home when I couldn't go out to get food for my family. You connected me to institutions that helped me with the rent. And I was treated very kindly when I received my coronavirus vaccination. Someday I will be rich enough to be able to pay you back for all you've done for me and my family. So if you listen to this story, there's actually a lot of data in there about the multiple different needs that were present, the ability to link an individual to resources, and as a result of that, the relationship that this individual had and their ability to receive important preventive health services. So it's important to remember the individual stories as we talk about the numbers. So our lessons learned from this project are that social needs are very common and underdiagnosed within clinical settings. Second, social needs affect health and healthcare, as Dr. Obeng-Gyasi has discussed in her talk. We also found that identifying these needs requires resources and institutional commitment. There were more than 30 individuals volunteering time and being reassigned from their regular roles in order to be able to identify and address social needs within the patient population at Erie Family Health Center. So that's substantial. But it's important to remember that sometimes we think that patients might be taken aback by us asking these questions. The vast majority of patients were grateful that someone cared enough to ask about their needs. We also learned that mitigating these needs requires strong and effective community partnerships, such as with food delivery programs. So being able to have a resource that we can link patients to is incredibly important once we identify needs. We also learned that measuring downstream effects will take time. So we are still in the era of COVID, sadly. And actually getting a mammogram after addressing a social need may take many months, maybe not the 30-day outcome that we're often interested in being able to measure and report on. So how do we effectively look and measure downstream outcomes? So I just want to end with a note of gratitude and acknowledgement to all of those that had supported this work over time. Certainly the Cancer Center at Northwestern, Erie Family Health Center, and our funders at Wintrust. I also have my contact information at the end of this slide for any that are interested in contacting me about this presentation. Thank you.
Thanks so much, Mita. Great overview of all the work you're doing in the community. So let's transition to our last speaker, who's Paris Thomas, and she's Director of Program Operations at Equal Hope. And she serves as a community health professional, really focusing on reducing healthcare disparities in underserved communities. And in addition, she's also a doctoral candidate with a research interest around community violence and health disparities, another element certainly of the allostatic load that contributes to poor health outcomes in many of the communities we're talking about. So Paris?
Thank you for that introduction, and thank you to the previous great panelists. So this presentation will highlight what a community-based organization is doing to address the social determinants of health. So Equal Hope, formerly known as the Metropolitan Chicago Breast Cancer Task Force, mission is to eliminate race, ethnicity, and class disparities in healthcare. We address these disparities through 3 program areas. The first area is our advocacy and policy realm, where we address and have grassroots advocacy efforts, and we work with local and state legislators to basically support health equity. Our second initiative is our Quality Consortium, where we gather entities and healthcare providers throughout the Chicagoland area to implement quality improvement projects. And our third area, which is our largest and community facing, is our outreach, education, and patient navigation realm, where we work with multiple entities here in the Chicagoland area to navigate underinsured women through free screening mammograms. So our program delivers services through community engagement, health education, and navigation to address access to care issues and improve the health and well-being of low-income clients with fewer resources. We address healthcare by providing free breast screenings, free cervical screenings, medical home placements, and access to a regular doctor, quality navigation assistance, and tools for prevention, detection, and screening awareness. We also provide assistance with diagnostic follow-up and breast and cervical cancer treatment. Equal Hope began from research showing that between 2005 and 2007, Black women were 62% more likely to die from breast cancer compared to white women here in the Chicagoland region. Even though they were diagnosed less often, causing us to believe the disparity was caused by a lack of access to quality care. This disparity did not exist, as you can see, in the prior years. We also saw that breast cancer disparity levels differed between cities. We compared ourselves to cities such as New York and San Francisco, where there was no breast cancer mortality disparity, suggesting that Chicago's healthcare system issues were diverse in its own. So in Chicago, where you reside matters. Highlighted in pink, you will see predominantly Black communities with high breast cancer rates. Many of these communities do have safety net hospitals available, but they are not imaging centers of excellence. Where you see the breast cancer women are our imaging centers of excellence here in the Chicagoland area. Because many of these communities do not have access to care at these imaging centers of excellence, they are lacking quality and being provided fragmented care, which was contributing to that disparity. After a decade of work, our research in 2017 showed that the breast cancer mortality rate had been reduced to 39%, and today it is currently at 32%. So Chicago is trending in the right way. But as mentioned before, Equal Hope was doing a lot of this work as far as navigating women to breast screenings and cervical screenings and entities like that. But as the pandemic struck, we saw that a lot of the women we serve had other needs and things that they needed throughout this time. So during the pandemic, we adjusted our navigation model to include navigation to the social determinants of health, or navigation through the social determinants of health. And we utilized hubs such as NowPow and the hubs to connect our patients to other entities that they'd be able to provide these assistance with. So as we did this, we also implemented and got a tool from our partners in Boston, which is the TRIP Project Social Needs Assessment. assessment, and we were able to assess all of our clients, not just those that were currently incoming into our program, but we actually went back through our database of 20,000 plus women and assessed all of these women for basically the social determinants of health. Questions, for example, that were asked were things around transportation, food, their housing situations, their electric and gas situations, as far as if they're having trouble paying for health care, if they needed time off of work, nutrition, unemployment, childcare, and phone services. So our navigators embedded this into their navigation protocol where any women that would call into our services would be assessed for these services so that we could provide them the assistance that they needed. Through this, we saw that many women had so many additional things that they needed, and there were so many barriers to these women getting their breast screenings. Many women had additional barriers where they didn't want to go to their screenings because of transportation, because of COVID, because of childcare and things like that. But we actually assessed over the last 2 years the support we were able to provide. 33% of our clients needed financial assistance, and were navigated to that. 38% needed additional medical services, such as dental and vision services. 8% needed insurance assistance. Another 8% were navigated to food assistance. 3% were navigated to employment assistance, another 3% to support group assistance, 3% to the COVID-19 vaccine, and 2% to legal assistance, and another 2% to housing. The support we were able to provide our clients really helped them throughout this time, especially those that were currently going through treatment. We especially saw that many of the women who were going through treatment couldn't focus on their treatment because they had these social determinants of health. We had women who had a lack in housing, and they weren't able to focus on their actual treatment because they were worried about having a roof over their head, had other issues such as food that was needed, and our navigators were able to provide that during this time to assist them with that. So over the next year, Equal Hope will continue to be a leader in the community and navigate these women through our services, and continue to support that cancer doesn't pause for a pandemic, as well as navigating people through their social needs referrals. So if you have any questions or would like to follow Equal Hope in our journey, please feel free to visit our website or give us a call at 312-942-3368, or visit our website at www.equalhope.org. We are also welcome in taking any women who are uninsured, underinsured, and providing them access to care and navigating them through the social determinants of health. Thank you so much.
Thanks very much, Paris. And now we come to the question and answer sort of discussion portion in the final 15 minutes or so. And I want to start out with a question that I suppose we could spend an entire day talking about, or have a symposium about. And you all alluded to it, and that is that there are a variety of factors that contribute to poor health and in these populations. And a lot of it goes, obviously much deeper. Back generations, there was redlining. People get segregated into certain communities. Their opportunities are limited. There's violence in those communities. There are food deserts. There's no trees. It's one thing after another after another. So we know that we can identify some of the causes of these things, and you've all developed programs that address some of this, but how do we get at the root cause, which are some of the things that I mentioned? This has to do with generational wealth. If you can't pass something on, you can never escape the environment you're in. So whoever wants to take a crack at that to solve the problem of our society, feel free. Clea looks like she has the answer.
Yeah, I'm happy to start with that. I think what you're getting at is, what are those most upstream factors that are influencing health and have been pretty recalcitrant over hundreds of years, at least, if not longer, in this country. And I think it's important to acknowledge that it's not going to be treated overnight. But what we can do as health systems, and remember, we're talking about this within the context of health, is that healthcare institutions are among the most powerful financially, as well as politically within an area. And so if there is the ability to take the knowledge, take this information, and advocate for policy level changes, For example, if we know that there are deserts in terms of access to healthcare, we could certainly address those. If there are gaps in how individuals pay and access healthcare, we can advocate for changes there as well. In addition, healthcare institutions are powerful economic engines. So we're one of the largest employers at Northwestern in the city of Chicago. So what is the role of where we recruit our workforce from? How do we train them? What are opportunities for advancement within our healthcare institutions? So I think, though it may seem like it's a big issue, I think healthcare institutions have either been a passive part of the problem, but have the power to become an active part of the solution.
Any other thoughts on that topic?
So I completely agree with what Mita said, in that I think that the main ways to address this is through policy change, but also through social-cultural change in terms of the cultures within institutions, and also diversifying the workforce, and not just recruiting, recruiting minoritized and also marginalized individuals, but actually retaining them. I think a lot of institutions do a great job of having people who historically face barriers come into their institutions, but once they get there, there aren't really resources to retain them. And that is something that I think that we need to work on to ensure that once people actually arrive, that they feel included, and then that their viewpoint can also help address some of the issues that we're facing.
Great. So to get to a bit more granular level with some of the questions, one of the things you were talking about, Samilia, is the concept of allostatic load and the elements that contribute to that. And one of the participants wanted to know if that's a validated tool, or is it something that's sort of subjectively put together and you come to a total and that therefore you get a number? What is that exactly?
So there are currently no validated allostatic load measures. A lot of the studies have been in retrospective populations with a few prospective studies, but the way that the composite is created is that they look at biomarkers. So for example, cortisol or body mass index or albumin. So it's a combination of vital signs that are routinely taken in clinics and also labs that are routinely taken in clinics. And then by representing multiple physiologic systems, these biomarkers are added to get a composite score. One of the things that we're hoping to do is to come up with a validated score that can be utilized across multiple clinics and hospital systems to make it easier to interpret the score between different populations or different hospital systems.
Great. And Mita, you might be able to address this at least at the outset. One of the questions was whether the needs, and you were talking about the needs that patients in general have that go unaddressed, is there a difference between men and women who develop breast cancer? Or, you may want to broaden it in general, but the question was more specific to breast cancer.
Well, I don't know the data around men diagnosed with breast cancer and whether these same allostatic load and downstream effects of that are different in men versus women. We do know that from the general population, where we're gathering a tremendous amount of data on the needs that exist within the communities, they're largely the same. Many of them are related to specific households and the experiences that households have. So it's important to remember that often if you are from a specific neighborhood or from a marginalized community, the chances are that others within your household may be from that same marginalized community and have the same historically restricted access to opportunities. So often the needs are the same between men and women because of the clustering of these within individuals by race, ethnicity, and by neighborhood.
Okay. And there was also a question coming across about whether you've identified any useful behavioral approaches, such as strategic messaging to help nudge populations at risk proactively to seek screening and services. And maybe we could ask Paris to address that, because it sort of segues nicely into the idea of mammography.
So yes, as far as behavioral approaches when addressing this, a lot of the women who are needing the screenings, we are able to navigate to, some of these social determinants of health referrals that they need as far as changes in nutrition and food and access and things like that. Those we, can can change. There are some things that we can't change as far as behavioral things, such as criminal backgrounds and things like that, such as we all know that the housing market is one of the toughest for individuals to get. So when individuals do not have access to housing, that is a huge barrier for them to access the quality screenings that they need. But us sending them through these social referrals does help them then go on and get their breast screening. And it's a way that we build trust with the community. All of our staff are from the community that we serve. We only hire within so that they understand who they're talking to, because we found that a lot of our clients are more comfortable with individuals who have came up in the same communities, understand the language that they talk, and they feel like they're not being judged. So we do use that to address barriers and get women to the quality screens that they need.
Can you, and on that topic specifically, just one more moment, can you comment on, there have been efforts in the past, whether it's men in barber shops for prostate cancer, women in beauty shops, the faith community talking about getting vaccinated. The same thing could apply to screening and so forth. Have those efforts turned out to be successful?
So yes, that is a great point. Those efforts have turned out to be successful in as far as increasing the amount of women that get breast screenings or those being navigated to the COVID-19 vaccine. We've used the same model to increase our community's awareness for COVID-19. So it is something that I think can be replicated across different cancers and different health disparities.
Okay. There's a question about if someone would comment on the intersection of social determinants such as food deserts and lifestyle determinants such as alcohol consumption and cancer risk. Mita, you want to start?
Sure, I'll get us started on that one. So there is a strong relationship. So to be clear, lifestyle and behavioral choices are one of the social determinants of health. So when we think about things like access to food and types of food, in some parts of Chicago, you may need to drive for 45 minutes to get to a fresh food source. So as you can imagine, that influences one's access to food and ability to exercise, eat healthy, etc. So a lot of those factors are clustered together. Also in areas that have what is often measured as neighborhood deprivation, there are higher rates of alcohol use, tobacco use, violence. So it's important to remember that often the things that we're seeing downstream as behaviors are the result of consistent and historic deprivation of those areas over time. So they are related.
Any other thoughts or comments on that one? All right. I guess you nailed it. So let's move on to triple negative breast cancer. Again, getting a little bit granular, but triple negative breast cancer, an entity that is often feared when patients hear that phrase because of its aggressive nature. And the question really speaks to the issue of whether some of the social determinants of health put individuals at a greater risk for developing that particular subset of breast cancer.
So studies have shown, and I think I mentioned this during the talk, that, for example, Black women who live in neighborhoods that are racially segregated have a higher probability of developing estrogen receptor negative breast cancers. Now, we don't have data specifically linking, for example, allostatic load to a higher incidence of triple negative breast cancers, but we do know that a higher allostatic load is associated with a higher probability of estrogen receptor negative cancer. So there is some signal for an association between low neighborhood socioeconomic status and also racial segregation and the development of estrogen negative breast cancers.
And I wanted to ask a question that, sort of the white guy on the call here today, if you didn't notice. One of the things that when we think about organizations, and I think, Mita, you were talking about it, Samilia, you were too, is you have to sort of look a little bit like the population you take care of. And when you're not well represented by the healthcare providers, it can have an impact on the ability to resonate with the patient population you're trying to develop trust with. So again, it's a very difficult question. How do you solve that one? It has to be a concerted effort at an organizational level, but perhaps you guys could comment on that.
So I would say one of the things, I'm sorry, Mita, do you want to go ahead? Okay. I would say one of the things that would probably be useful is to, especially for junior faculty who are entering a new organization or junior clinicians, is to create mentorship systems or sponsorship systems that can actually get these individuals engaged within the organization and can also help them plan out their career and see how they fit into the organization. I think that without that kind of support, one can feel very socially isolated, and then it's difficult to understand how you can progress or integrate yourself into an organization.
I think there are actually a fair number of guides on what institutions can do to ensure that their workforce is more representative of the population served. First is recognizing it didn't happen by accident that our workforce is not representative of the populations we serve. Second, there are active processes we can take to ensure that inside the house, our processes are all set up. So if we're going to recruit someone in, have our ducks in order, right? So how do we actually assess individuals? So for example, if we are valuing patient-reported scores on satisfaction, we should know that differs by race, ethnicity, and gender systematically. We should know that opportunities for promotion are not equitably spread across individuals. So I think we need to put processes in place to ensure that we are able to not just recruit, but retain and promote. Third, we need to be able to make sure we go to the places, where we have a wealth of experience and knowledge, and ensure that we are showing up, not putting an ad out there and saying, come on over to us and why isn't anyone coming in? So ensuring that we actually are proactive with our recruitment processes and meeting people where they are and understanding. I think those are three of the critical parts of ensuring that we start developing a workforce that is more representative of our population, because it does actually enhance the quality of care that we deliver.
Great. And I think we're going to end with that comment. And I want to thank Samilia, Mita, and Paris. I know that we only barely scratched the surface of this topic. This is a symposium that can be conducted over days, but hopefully it highlighted some of the issues that we all confront, not only locally, but nationally. And with a concerted effort, hopefully we'll improve things for all our patients. So again, thank you for the faculty, and I want to thank everyone who listened into this session.